So.
And can you just briefly talk to us about so the subchondroplasty versus things like nanofracture, and where you'd use one versus the other, perhaps?
In osteoarthritis, I suppose we could describe it as a journey. The nanofracture, which is use of a 0.9 millimeter fine pick to stimulate healing by really going beyond the subchondral bone to get to what we describe as mesenchymal area, is what we do for the local or focal cartilage defects. So let's say, for example, a 25-year-old who has had an injury playing football or basketball, and we've isolated based on their clinical and imaging studies that they've got a focal defect under 2.5 centimeters. And in those instances, we look to see if just a focal cartilage defect, then we offer them nanofracture. In the United States, I think they have microfracture, but my experience with microfracture is that a lot of the patients not very pleased with keeping off weight on, and being on crutches for anything from 6 to 8 weeks. With a nanofracture, the patients can start fully weight bearing within 2 to 3 weeks.
Okay, that's a big difference. Yeah, I mean, I can talk from a little bit of experience there, having had a microfracture some years ago, and another big repair, which I won't bore you with. But the worst one, I was on crutches for 4 months, and that was nearly sent me mad. So yeah, I can definitely relate to that.
Indeed.
That's really fascinating. So in terms of the subchondroplasty and the nanofracture, so again, inclusion criteria being, again, correct me if I'm wrong here, Harold, but with things like the nanofracture, again, the idea is you are trying to aim for a little bit of cartilage filling in, stimulating those bone marrow cells, as you say, to sort of stem cells to come up and fill in a little bit of hyaline-like or chondral-like cartilage as best you can. But I'm thinking right in saying the inclusion criteria for that, as you mentioned, is the lesion must be no bigger than 2.5 centimeters, and I'm also right in saying it tends to be done only if there's like a single lesion in the knee. So if you've got pockets like if it's like a road where you've got one little pocket, fine. If you've got a road, but you've got multiple divots and multiple potholes, it becomes a bit more difficult to, well, almost doesn't really not be appropriate for nanofracture. Is that right?
It's difficult, but I think I wouldn't rule it out, because examples of sportsmen who've actually had the nanofracture include some of the semi-professional footballers who have localized focal chondral defects, or we can describe potholes, probably the best way to look at it. So potholes in either the trochlear groove, the medial femoral condyle, the lateral femoral condyle, and we'll offer them that. And again, the size matters, because what we want is to have a contained focal defect that we can work on. The subchondroplasty side of things, interesting point you make, because so far most of the patients I've operated on are over 40, and they've got some degenerative change, but they have also got diffuse cartilage loss. So there's no pothole, so to speak. So the use of a nanofracture, in my experience, hasn't been very good. So in those instances, I consider them for subchondroplasty.
Right.
But that's the older age group.
So you're saying in those instances, there's just like a generalized wearing down of the cartilage, as opposed to the potholes as such in the younger group. But with the nanofracture, though, you're saying you can use it on multiple or more than one, at least, pothole per knee.
I can, and I have.
Right.
I can. Again, these are anecdotes, but I do recall the beauty of endoscopic procedures. You can look throughout the knee.
Yeah.
And if you identify any areas where there's a focal defect, it's not just in the medial femoral condyle. Some patients present with patellofemoral pain, and you find that they've actually got a focal defect. For the trochlear, it's relatively easy. The patella is more difficult, and patella can be quite unforgiving.
Okay. And is it so would you use it try it on a patella, or never go there with patella?
I would, but often it's in conjunction with another procedure. In some of the patients with patellofemoral disorders with a focal defect in the patella, I've combined the nanofracture with what we describe as it's a bit of a mouthful, matrix-induced autologous chondrocyte implantation.
Yeah, or MACI for short, yeah?
Or MACI for short.
Yeah.
But
Okay.
I just remember MACI in America. There's a MACI in America, isn't there? That's a Y one, MACI. Yeah.
And okay, so that's a great little one to dive into. So, and what's been your results then with the MACIs with patellofemoral problems? Because that's traditionally, like you say, it's from what I've researched in the past. That's always been a trickier area to treat. I think, as you mentioned, so the patellofemoral, it's a sliding surface. It's not quite the same as the typical femoral joint. But yeah, what's your experience?
Yeah, I've done 5 and I've had only 3 really satisfied patients.
Okay.
The first one I did, as usual, when you have your first one and they're really delighted, you're very pleased because that's the right procedure. And that took a long time. The second one, we had to do a mini open, which made the operation even quicker. And he was satisfied. But the 21-year-old and the, I think the 25-year-old, they found it difficult. It was still painful. But in hindsight, it may be because they still had some bone marrow edema.
Okay, brilliant. So, I mean, that's already been a fascinating interview already. So, but let's now get into a little bit in terms of you mentioned earlier on, knee replacement. So, we're then thinking the older age group, obviously 20s, 30s, it's not really appropriate for because they're gonna need another one in their 40s. They're gonna need another one in their 50s. It's just not really a sensible option. I mean, the youngest I've heard of people having knee replacements, I think, is perhaps 40s, but and maybe 50s, but it tends to be 60 and older. Is that fair to say? Yeah.
Yep, indeed.
What's your experience? What's your opinion? What's your there's lots of debates in the industry in terms of should you go with robotic surgery? Should you not? What's your take on robotics?
I think robotics surgery has certainly got a place. The procedure does take a bit longer than the conventional knee replacement. I think there's a lot of focus on alignment, but my personal opinion is that when you use robotics, you need training, the staff need training, and it does take a bit longer. But you can probably call me a dinosaur, but there are other methods of management, such as patient-specific instrumentation or patient-specific implantation. So bespoke type, if required. For a standard knee replacement, in the hands of somebody over 45, the process is based mainly at looking at alignment, and there are templates now that you can have preoperatively to ensure you get the right alignment and use the right polyethylene thickness to actually enable the patient to have a successful knee replacement.
Does that involve like CT planning and CT kind of pre?
Yes, it often involves CT planning or even X-ray planning. For the majority, is X-ray planning, where you have a software that allows you to really determine what implants to put into the patient. But we don't rely on just that satellite navigation type of treatment. If it feels right, because of the number we've done over the years, in my case, over 20 years, you have an idea of the alignment because you see it on the table, and you actually range the knee motion before you close up. And if the balance is right, then the knee will move as it should.
Yeah. Okay. Fascinating. And then another kind of hot topic, let's say, is the, I think you mentioned or touched on it, is things like the custom knees and the bespoke knees. So things you may have heard in the press, we've got the conformist knee, where it's the idea is that they're trying to do they're doing a 3D mapping of your own knee to try and give you a prosthetic knee that is literally contoured and shaped to the size and contours of your original knee. So the idea is trying to feel as natural to the patient as possible. And the debates go between things like the patient satisfaction, number one, but then also where how can you rely on it? Because if they've got a faulty biomechanical knee and you're replacing it with a faulty biomechanical, it might feel great, but is it then going to wear out quicker? What's your take on that whole kind of debate? Are you a fan? Are you not a fan?
I'm a fan, and the reason why I'm a fan is it doesn't apply to all patients. I often have patients with malunited fractures of the femur, and what we do for a knee replacement, we use an intramedullary guide. And so we put a metal rod through the femoral canal to give us an idea of the, 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 the procedure for the cuts and for implanting the knee in a satisfactory or perfect position. I've used Conformis. I do like Conformis. Conformis, there are other companies. Zimmer does them, Symbios, and Depuis, to name a few. What I like about Symbios is that it looks at the medial and the lateral compartments. So the polyethylene is separate. You've got polyethylene for the medial side, polyethylene for the lateral side, whereas in a lot of the other knee replacements, the single polyethylene. Right. So it takes account the thickness of the polyethylene in each compartment. Oh. And my experience has been quite positive. It's something that I've used in, I think I used in a 41-year-old, only because I was anxious to make sure that we got the balance right. And a conventional knee might have been okay, but I was quite pleased using Conformis. My personal opinion is that a lot of the implants that I use can be off the shelf. There are instances where I will use Conformis in the young patient, in the patient with patellofemoral malalignment, in the patient with a malunited fracture of the femur. I think what the theatre staff like most about it, from what I've been told, is that it's ergonomic. You can use 2 trays for your operation, whereas a standard knee replacement might need 4 or 5 trays.
So by trays, really you think about plastic or polyethylene?
Oh, I beg your pardon. The instruments that we use for the knee procedure.
Actual trays, you mean?
Yeah, the actual trays. Yeah. The actual trays for the knee procedure in theatre is confined to about two trays, whereas in the standard knee, it's 4 or 5 trays.
Oh, okay, right, excellent. So, am I right in hearing then you're saying then in let's say the younger age groups, the 40s, the 50s, and the more active, then you're tending to go more in favour of those bespoke knees. Is that right? Because of various reasons, it's going to feel better. They're going to feel happy when they're active, and what about things like cruciate sparing? Is that a factor as well?
The Conformis that I use is cruciate sparing, the PCL sparing, or what we describe as CR, cruciate retaining. I've used Conformis in the younger patients, but really it's often down to the individual. I mean, you'll have a patient who presents, who's read everything about Conformis, knows somebody's had a Conformis, and would like to have a Conformis knee replacement. And there are those who I will give the information regarding Conformis and the information about the implant that I particularly like to use, and they have that decision. Sometimes they will ask me, what would I recommend? And I will recommend the standard off the shelf, depending on the patient. But the very active individuals and young individuals, I start to think about bone conservation. One of the advantages of the Conformis is that you cut less bone.
Right.
So should they need a revision?
A thing to revise later on. Is that what you mean?
Yes, that's I think that's the idea, really, to try and save as much bone as possible, so that when you do have to revise, there's less, there's enough bone, so to speak, compared with a standard knee replacement.
Got it. Excellent. Is there any information on? Again, that's a difficult question. It's going to vary, very massively with, as you said, all different factors. But is there a rough rule of thumb with regards to, if somebody has a successful, whether it be Conformis or Symbios, one of the others, but these bespoke knees, is there a rough rule of thumb in terms of how long they might last as compared with the off the shelf? Is it a case that they're going to last not as long, but they're going to be easy to replace, or is there a gauge on that?
That's an excellent question, Rob. I've got someone's giving me a mild headache at the moment, because I introduced him to the ODEP rating, which is the Orthopaedic Data Evaluation Panel. And he's an engineer, and what we talked about was based on what evidence there is. Conformis, Symbios, great implants, but a lot of the off-the-shelf prostheses have 10, 15-year results, which are excellent. And the particular one I use, I don't know if I can mention it, Zimmer mentioned already, it has 13A rating, and so the higher the number, I suppose the higher the longevity. So a 13A rated prosthesis is something that has been around for longer.
Right.
And so in this instance, it is very likely this particular patient will go down the route of the ODEP.
Okay. And what was the name of that one again? You said it. Sorry, is it what? Which type of?
Next gen. It's actually next gen Zero environment.
Oh, okay.
But what's interesting, Robert, a lot of more patients are actually asking really good questions.
Yeah.
And this engineer, he asked me about the composition, and I welcome it. I think it's fantastic.
Yeah.
The composition of the implant, the manufacturing of the polyethylene, the comparison between polyethylene that hasn't had vitamin E infused into it, and in his opinion, will he be able to return to activities that he enjoys doing? He likes climbing, he likes cycling. And I said, yes, he can. The first consultation started with him presenting the conformist. And he'd read an article about somebody who'd, I think they climbed a mountain. I can't remember which mountain. And he was.
We're talking total knee here, not partial. We're talking a total.
This is total knee. Yeah. And he was delighted. So he wanted to find out a bit more about it. And then we went down the route of ODEP rating. And I think he will probably be pushing towards the ODEP rating.
So is that a case that then it's just that there's you know, like you say, they've been around longer and therefore there's more data? Is that what it is?
There's more that. Yeah. Indeed, it's more data, and if it hasn't been changed, I think if it's been unchanged, usually that is what they concentrate on.
Okay,
so once it's changed, sorry, go on.
Yeah, I was going to say. So it sounds like there's a lot of anecdotal, a lot of happy patients out there who have had conformists and others, and as you say, it's kind of, yes, there's data, but they've had it in the last 5-10 years. It's not like they haven't had, you know, the next gen that's been around for umpteen years, and therefore it's not, you know, you can't pin your hat as much on it because you don't know where they'll be in 5-10 years time.
Absolutely. But I always want to give them informed choices so they can know the pros and cons.
That's really good. And then let's we'll have to try and wrap it up soon, so we don't want people to get bored watching this video. But not that we'll get bored. I'm sure it's been fascinating. But in terms of things like patellofemoral joints, so you know, that I think there's often a decision to be made. Even I think I'm right in saying even within total knee replacements, you know, whether the surgeon replaces the kneecap, doesn't replace the kneecap. I guess that comes down to whether there's disease in the kneecap. And obviously, if the kneecap's pristine, you know, no reason to change it. But if let's say somebody has got, you know, wear and tear in their patella, is that a game changer in terms of having a total knee? Does that then mean they've got less, their prognosis is not as good? Or again, what's your thoughts on that?
Well, Rob, opinion is divided. If you have isolated patellofemoral arthritis, there are surgeons who will look at the patient, and if the patient has end-stage arthritis, that means, you know, straight down to bone, and the tibiofemoral compartment is pristine, there is a group that will consider just isolated patellofemoral replacement. They'll do other things first, including, you know, the non-operative measures. Some will arthroscope the patient, some will inject their knee to see how their response is to the injection to the knee. And then there's a group who perhaps I was in that group until about 6 or 7 years ago, who looked at the literature and found that the patellofemoral joint replacement results were not very good. And it may have been due to design of the implant or a number of factors. And they found that the patellofemoral replacement was actually failing. And in those individuals, surgeons would opt for a total knee replacement. Now, if we're looking at knee preservation, that seems like a no-brainer. You've got somebody with just isolated patellofemoral arthritis. And some studies indicate it's 20% of the population of the knee patients. In my experience is less, certainly in my practice, less than 5% of patients have isolated patellofemoral arthritis. And I have, touch wood, been successful with patellofemoral, I tend to call it resurfacing, because when you replace the patellofemoral joint, you have to be accurate enough to make sure that you haven't pushed the patella outward, increasing the tension on the quads. or that you haven't got a malalignment in which the patella slips off the side. So I tend to go for a patella resurfacing, but it's probably one or two a year for me.
Right. So that is a case of replacing the trochlea, is that right? And then putting a button on the patella, is that right?
Absolutely. And I tend to like to call it resurfacing. So I use an implant that sits in a crater that we've created in the femur, in a trochlea, and then a button. So it means that the forces across the knee hopefully haven't been changed. And in those instances also we look at the alignment, because if they've got isolated patellofemoral arthritis, there may be a malalignment. What I mean by it is that the patella might be translated laterally, increase the forcing across the knee, and that would have to be addressed too.
So as far as that patellofemoral articulation goes, though, and say in an isolated patellofemoral resurfacing as you just described, is that pretty much the same thing as you're doing in a total knee, or does that differ in a total knee?
It differs in a total knee because the femoral component is quite a large component, so it covers the trochlea too. And there are mixed papers on whether to resurface patella or not. And the conclusion, certainly in my experience, is based on the implant. This implant that I prefer to use, even if they have degenerative change in the patella, they can manage without resurfacing of the patella.
Right. Wow. Okay. Interesting stuff. And if then they had to let's say they had that resurfacing, but then some years down the line they then had to come back to you and go for a total knee or partial knee, is that an easy job to do, or does that?
Yeah, in my hand, it's an easy job to do because of course you've saved bone. And the indication for the revision. We don't take revisions lightly because often there's a number of causes of this and patient expectation. I mean, I remember years ago, patients telling me that I've come to see you as second opinion because I was told I'd be, walking up, the Kilimanjaro at a year after my knee replacement, and it's 6 months and I've got a plan on what I want to do and I'm still in pain. And then their jaw drops when I say it takes up to 2 years to recover from a knee replacement. Some will either say, well, no, I thought it's for old people, or some would say, well, no, I think I'll be fine. And then they find that it's not just the knee itself, the soft tissue, or the activities that they do. So I say to them in 2 years.
Wow. Okay, that's good for people to know then. Yeah, so it's a quite a big deal.
Yeah, indeed.
Where do you see the future going with these sorts of things, Harold? In terms of, do you think there'll be, does the future hold in terms of less bearing surfaces and different, like say even better? I know there's newer grades of polyethylene now. You mentioned the vitamin E infused polyethylene, but do you think other materials will come in terms of going from metal towards ceramics or even pyrocarbons, or is there a direction that things are heading in with regards to that?
The direction is they're looking at the bearing surface at the moment is highly cross-linked polyethylene with vitamin E to reduce the free radicals that degenerate the polyethylene. Some have looked at ceramic, but I think they've looked at it from the allergy point of view, because a number of patients have been found to be nickel allergic.
Okay.
I have no experience of use of the ceramic or the oxinium, which is one of the companies uses a layer of ceramic. I think the direction that it will take, it's going to be based on either using 3D planning and 3D printer for individual implants, but still using the same type of metal implants with a polyethylene liner. And I suppose what we would be aiming for is to try and delay the need for a knee replacement as the end stage of treatment of knee arthritis. So maintaining the joint as long as possible, supporting the tissues, looking outside the knee and the hip to try and actually improve the individual, and looking at lifestyle. It's incredible that it's probably been around for so long, but in the last 10 years, people are really looking at lifestyle, looking at, I think somebody called it dietary inflammatory load.
Right.
Don't worry, I don't understand that either. But they're looking at the dietary index to see if the constitution of an individual's diet predisposes them to osteoarthritis. Because at medical school, what we learned about was mainly injury and patients with cartilage problems. But looking at lifestyle, looking at diet, is becoming such a big thing now.
Yeah, big hot topic. And I mean, one of the things I think read relatively recent in the last few years is there's a fascinating piece of research that showed something like, even just in simple terms, things like, just looking at your BMI, your body mass index, and if people lost something like 10% of their body weight, it often then led to a 50% reduction in their knee pain.
Yeah,
that might be exact figures, but it was something like that, and as you say, just how big a factor the biomechanics, their overactivity and lifestyle can be. So yeah.
And I've had an interesting, Rob, sorry to interrupt, I've had anecdotes when the lockdown was eased and, get coronavirus, and we had telephone consultations, and you'd ask patients, well, how have you been during the lockdown? And how's your knee? And some would say, oh, you won't believe it, doctor. I've been doing exercises, I've been following XYZ on YouTube, and I've lost weight. And I feel that my knee's better. So I don't want anything. Thank you very much. Goodbye. On the other hand, of course, I've had I think, is it a couch to 5K run?
Yeah.
It's usually men, unfortunately. We men, so we get off the couch and start exercising. But those are usually, meniscal injuries.
Yeah. We've seen a few lockdown injuries as well but no, you say there's pros and cons, isn't there? So, but no, that's interesting. Very, very interesting. Well, Harold, that's really, really fascinating. Great talking to you as always. And
you too,
thanks for your time today. And I hope everybody who's watching this video found that really as interesting as I did. And we'll talk again, perhaps at another topic.
Marvelous. Indeed. Stay safe.
Thanks again. Take care.
Thank you. Bye.
Right.